Welcome to Leveraging HOPWA and other public funding to improve HIV health, housing, and employment outcomes. My name is Amy Paulonis, and I am the Deputy Director of HUD's Office of HIV/AIDS Housing, which is the office at HUD that manages the housing opportunities for persons with AIDS, or HOPWA program nationally. In this webinar, presenters will provide an overview of the Health Resources and Services Administration's Ryan White HIV/AIDS Program Special Projects of National Significance Initiative titled Improving Health Outcomes Through the Coordination of Supportive Employment and Housing Services, also known as the HIV Housing and Employment Project. My office at HUD partnered with HRSA and DOL, the Department of Labor, on this initiative, and we are excited to share information and lessons learned from the HIV Housing and Employment Project in this webinar geared to HOPWA grantees and providers. Next slide, please. So just some housekeeping before we get started. This webinar is being recorded, and the recording will be uploaded to the HIV Housing and Employment Project website. The link to that website is on this slide. To minimize background noise, all attendees will be muted for the duration of the webinar. Please don't hesitate to ask questions to any of today's presenters. To ask a question or provide a comment, you'll just use the chat box, and presenters will do their best to answer all questions at the end of the presentation. Next slide, please. So I am happy to introduce today's presenters. In addition to me, we have Kristen Lasko from one of the project sites, Fenway Health in Boston, Massachusetts. We also have Tanya Kaufman-Mendez from another project site, Bexar County Hospital District in San Antonio, Texas. And we have Jessica Flaherty from Boston University School of Social Work, which served as the Evaluation and Technical Assistance Provider, or ETAP, for this initiative. And I just want to thank Jessica and the rest of the Boston University team for coordinating the development of today's webinar. And then in addition, we have Corliss Heath and Chow Win from the Health Resources and Services Administration HIV/AIDS Bureau. They both serve as project officers on this initiative. They won't be presenting any content today, but they will be available to answer any questions regarding the initiative as needed at the end of today's presentation. Next slide, please. So for the learning objectives, at the end of this webinar, participants should be able to describe how housing instability affects people living with HIV and the role that the HOPWA program has in supporting people living with HIV with housing and services. Learn strategies to leverage HUD and other public resources to provide housing and employment services for people living with HIV. Share methods for integrating HOPWA measurements for tracking housing stability and housing outcomes for people living with HIV, and learn how the initiative's models of care coordination affected clients' HIV health outcomes, housing stability, and employment status. So before we jump into the content, I just want to thank Corliss and Chow and the rest of HAB staff and leadership for their continued partnership on joint initiatives such as the one we'll be discussing today. We at the Office of HIV/AIDS Housing have been lucky enough to be able to partner with HAB on a few recent SPNS initiatives that have led to better coordination between Ryan White and HOPWA programs, as well as improved outcomes for people living with HIV. So with that being said, we can move into today's presentation. Next slide, please. So I know most people on this webinar are familiar with the basics of the HOPWA program, but for those that may not be, I am going to start with a little bit of background on HOPWA before we move into the specifics of the HIV Housing and Employment Project. Next slide, please. So as I mentioned, the HOPWA program is managed by HUD's Office of HIV/AIDS Housing. It is the only federal program specifically dedicated to the housing needs of low-income people living with HIV. Under HOPWA, HUD makes grants to eligible cities, states, and nonprofits to provide housing assistance and supportive services to low-income people living with HIV and their families. By providing housing assistance and supportive services, the HOPWA program helps people living with HIV enter and remain in housing, access and maintain medical care, and adhere to HIV treatment regimens. And we know that safe, stable housing is closely linked to successful HIV outcomes. Basically, people are able to do better in their HIV care when they have a stable living situation. Next slide, please. So the annual HOPWA appropriation or budget that the program receives from Congress each year is divided between two programs, 90% for formula program grants and 10% for competitive program grants. You can see on this slide that Congress appropriated $430 million for HOPWA last year for fiscal year 2021. This slide was developed before we knew the HOPWA funding level for fiscal year 2022, which is $450 million. So a $20 million increase over last year. For HOPWA formula grants, they are made using a statutorily mandated formula to allocate funds to eligible cities on behalf of their metropolitan statistical areas and to eligible states. And those allocations are made based on HIV case data, housing costs, and poverty rates. Eligible competitive grantees are states, local governments, and nonprofit organizations. Those awards are based on competitive applications, but each year Congress prioritizes the renewal of existing permanent supportive housing projects before the Office of HIV/AIDS Housing can fund any new HOPWA competitive projects. So basically, if funds remain after the renewals are fulfilled, they are distributed under a new competition. And we actually were able to fund a new round of competitive grants last year, which was the first new HOPWA funding opportunity in over 5 years. And we announced those 20 new competitive grants this past World AIDS Day on December 1st. So between the formula and competitive programs, there is local HOPWA funding in all 50 states, DC, Puerto Rico, and the US Virgin Islands. And so HOPWA grantees can either choose to implement eligible activities directly, or more commonly, they subcontract with what are called project sponsors or subrecipients. And the grantees contract with those project sponsors to carry out the housing assistance and supportive services. And project sponsors can be nonprofits or governmental housing agencies. And overall, across the country, there are almost 1,000 project sponsors. Next slide, please. So the HOPWA regulations provide a flexible range of eligible activities that grantees may choose to implement in their community. What each grantee chooses to fund must be based on local needs and documented in their consolidated plan for formula grantees or their approved competitive application for competitive grantees. Eligible activities under HOPWA include facility-based and scattered site emergency, transitional, or permanent housing. And this includes project and tenant-based rental assistance, short-term rent, mortgage, and utility assistance to prevent homelessness of eligible individuals or families that rent or own their homes, so homelessness prevention activities, permanent housing placement, which is cost to get eligible individuals or families into permanent housing, such as security deposits, application fees, credit checks, utility hookup fees, and other relevant costs. Housing information services, which includes counseling, information, and referral services to assist eligible households to locate, acquire, finance, or maintain housing. And then a wide range of eligible supportive services, including case management, nutrition services, transportation services, employment and vocational training, education, childcare, mental health and substance use treatment, and other services to improve housing stability, health, and well-being of assisted individuals and families. And then we have Resource ID to establish, coordinate, and develop housing assistance resources. And those are basically costs for systems level coordination activities, needs assessment, collaborative planning efforts, things like that. And then finally, we have administration costs, which are costs for management, oversight, and reporting, which are capped by statute at 3% for grantees and 7% for project sponsors. Again, this is just a high-level overview of the types of activities that are eligible by statute and regulation, with the specific activities or combination activities each grantee chooses to fund with their HOPWA grant is based on local need and decision-making. Next slide, please. So this slide shows how grantees choose to spend their grant funds. You can see on the slide that last year, 74% of HOPWA expenditures were for housing assistance, 18% was spent on providing supportive services, 6% on administrative costs, 1% for housing information services, and then another 1% for housing development. So few grantees choose to fund housing development that I didn't pull that out and specifically mention it on the last slide. But acquisition, new construction, rehab, and repair of housing facilities are eligible under HOPWA, but only approximately 1% of HOPWA funds are utilized for development purposes each year. Next slide, please. So I'm going to end the HOPWA overview with just a little bit about who HOPWA serves. Over 100,000 households receive HOPWA housing assistance, supportive services, or housing search and placement services annually. 77% of HOPWA beneficiaries served are extremely low income. Among new clients served last year, approximately 3,400 or 16% were experiencing homelessness at program entry. Over 60% of HOPWA eligible individuals served under the program are male. 43% are between the ages of 31 and 50, and 45% are 51 or older. Over half are Black or African American, 37% are white, and 19% identify as having Hispanic or Latino ethnicity. So that is it for my very basic overview of the HOPWA program. You can go to the next slide, please. So I am also going to provide another high-level overview of the HIV Housing and Employment Project, just so you have some background and context before we get into the presentations from the project sites and the evaluation and technical assistance provider. Next slide, please. So what is the HIV Housing and Employment Project? So it was a Special Projects of National Significance, or SPNS Initiative, supported through the U.S. Department of Health and Human Services Minority HIV/AIDS Fund and the SPNS program under HRSA's HIV/AIDS Bureau. As I mentioned earlier, the initiative was conducted in partnership with my office, HUD's Office of HIV/AIDS Housing, as well as the U.S. Department of Labor. The initiative supported one evaluation and technical assistance provider, or ETAP, which is Boston University, as well as 12 demonstration sites across the US, which 2 of those sites you will hear from today. Next slide, please. So you can see the locations of the 12 funded sites, as well as the evaluation center on this slide. 4 of the sites were city or county health departments. 4 were HRSA health centers, and another 4 were AIDS service organizations or HIV comprehensive care agencies. Next slide, please. So as both housing instability and lack of employment can decrease engagement in HIV care for people living with HIV, the HIV Housing and Employment Project was created to support the design, implementation, evaluation, and dissemination of innovative interventions that coordinated HIV care and treatment, housing, and employment services. These interventions aim to improve HIV health outcomes for uninsured, underserved people living with HIV from low income and racial and ethnic minority communities. Next slide, please. So all 12 funded sites use intervention models with care coordinators or navigators to coordinate HIV care, housing, and employment services. 3 sites implemented case management training across providers and partnering agencies. 3 sites refined their mechanisms for receiving and making referrals for services based on client needs. 2 sites improved their data systems and integrated them with other internal departments and external agencies to better coordinate care for clients. 8 sites either received or partnered with agencies that received HOPWA funding. And 3 sites partnered with Department of Labor funded agencies. And again, we'll hear specifically from 2 of the funded sites today about the interventions they implemented and partnerships they formed through this initiative. Next slide, please. And so finally, for client eligibility criteria under the initiative, clients needed to be 18 years or older and a person living with HIV who was either newly diagnosed with HIV, had missed recent HIV primary care visits, was at risk for falling out of care, or was not virally suppressed, and were homeless or unstably housed and unemployed or underemployed. So that was a very high level of overview of the HIV Housing and Employment Project. I am now going to turn things over to Kristen Lasko, Director of Housing Services at Fenway Health, to tell you more about Fenway's project model and lessons learned. Thank you.
Wonderful. Thank you, Amy. Hi, everyone. As Amy said, I am Kristen Lasko. I'm the Director of Housing Services at Fenway Health. I use the she series pronouns, and I was also the project manager for our SPNS initiative for the duration of the project, which was a real pleasure. Next slide. So at Fenway Health, we had 3 legs, so to speak, of involvement to create our SPNS initiative. The first was the health center. So at Fenway Health, we are a federally qualified health center with Ryan White Part A funded case management. Within Fenway Health, the public health division is called AIDS Action. And in AIDS Action, we provide housing services funded by HOPWA, Ryan White, and state funds through the state of Massachusetts. And then our third leg of the partnership was our employment services partner, which was JVS Mass Hire Downtown Boston. And they are a Department of Labor funded employment services provider. So I'll get into all of that in a little bit more detail, but just to kind of set the scene there. And so within our initiative, we had 2 main project goals. One was the integration of employment services into our existing clinical and housing services program. And then the other was around internal systems strengthening, the connection between our medical case management and housing programs internally within Fenway Health. Next slide. All right, so as I already said, Fenway Health is a federally qualified health center. We have received Ryan White Parts A and C funding for quite a while, and we are the largest non-hospital provider of HIV, AIDS medical, and behavioral health services in Massachusetts. So we are seeing a lot of patients annually who are living with HIV. We also have a very robust medical case management program, which is funded in part through Ryan White Part A. Next slide. AIDS Action historically is, or was perhaps, the oldest and largest AIDS service organization in New England. So when I started in this work, AIDS Action was a standalone nonprofit organization, And then in 2018, we officially merged. So Fenway Health and AIDS Action merged after a 5-year strategic partnership. And so currently, AIDS Action is the public health division of Fenway, and we focus on prevention and social determinants of health programming for HIV care and prevention services. So we do a lot of housing work. We also operate prevention programs such as needle exchange and overdose prevention. We offer linkage to care and short-term navigation services. And we have an in-house legal department, which I won't talk about any further in this presentation, but is a huge asset for all of our clients, definitely. Next slide, please. All right, and so then to get into a little bit more detail about the housing programs that we offer within AIDS Action, we have 3 main programs. The first is housing search and advocacy. And so we serve hundreds of households a year, providing housing search services, some focusing on clients with vouchers, some focusing on clients who are experiencing literal homelessness, and then also a broader range of services to people who are experiencing any form of housing instability. And some of that funding comes through HOPWA, Housing Information Services. Our rental assistance programs assist clients in a couple of ways. So the first way is through short-term assistance, background, short-term ongoing rental assistance, startup costs, emergency utility payments, and some of that funding comes through STROMU and PHP from HOPWA. And then also within our rental assistance programs, we administer ongoing TBRA and then also ongoing rental assistance through some COC programs. And finally, we provide supportive services. Again, we receive a nice amount of HOPWA money to support that program, and we provide housing stabilization, and we serve households, in particular supportive housing programs, some of which we administer internally through the rental assistance programs. And then in other cases, we're providing the supportive services and we are partnering with an external agency that administers the rental assistance, which I'm sure is a model familiar to many of you. Next slide, please. All right, so within our housing department, we are just constantly thinking about how we are partnering with our internal programs, but also other agencies within the broader scope of HIV service delivery in our area, which is again, the greater Boston area in Massachusetts. And so we really thrive, I will say, on our partnerships with HRSA funded medical case management agencies where we are providing HUD funded housing support, and then the clients are also receiving medical case management funded through often through Ryan White. So our housing programs are serving both those who are Fenway patients and those who receive care elsewhere. We are flush with clinical institutions, hospitals, community health centers in this area. And so we are not only serving clients who receive their medical care at Fenway, but who receive their medical care elsewhere. Our housing programs really rely on these partnerships, and we detail those relationships through MOAs with our referring partner agencies, where we outline the process of referrals to things like rental assistance and housing search, and detail the expectations for ongoing coordination. We really work very closely with the case managers at those other locations and really try to frame our services as a piece of a whole of both the medical and social determinants of health kind of supports that clients need. Next slide, please. And then internally, when we think about leveraging funds for program cohesion, this is huge for us. All of our programs are funded by multiple sources. Tried to highlight the HOPWA funding earlier, but we're receiving funding from other sources as well. So just to use our rental assistance programs as an example, we're serving hundreds of households a year. We want to be able to support households throughout the state of Massachusetts. And so we pieced together our funding from the Massachusetts Department of Public Health, which is state money, as well as our HOPWA, STROMU, and PHP, both through the city of Boston and then also through the city of Cambridge. And then in addition, we receive housing assistance from Boston Public Health Commission through Ryan White Part A. So again, I'm sure this is familiar to many of you, but put all that together and create a cohesive program with one set of eligibility criteria, a single application where the client doesn't know, oh, I'm applying for HOPWA or I'm applying for Ryan White Part A housing assistance. They just know that they're applying to the rental assistance programs and what the eligibility criteria is. Next slide, please. Okay, so all of that, I hope, sets the stage of where we were coming from when we started this SPNS initiative. None of that was specific to SPNS. It just sort of lays the foundation of where we were beginning. So again, we had two big goals in our SPNS initiative, and the first was integrating employment services into our existing health center and housing program operations. So to do that, we were one of the agencies that partnered with a Department of Labor funded site to provide coordinated employment services to our clients who were accessing existing medical case management and housing services. Next slide. Okay, and so to do this, we established this partnership with a particular location, Mass Hire, downtown Boston. And so when we were looking for a partner for this project, or even broader than that, when we were thinking about a way to integrate employment services into our existing programming, we decided that partnering with one specific agency and really trying to strengthen that relationship rather than making a lot of different looser connections was the way to go. So we developed a relationship with Mass Hire downtown Boston. We were really impressed by their robust catalog of services, some of which are listed here. And we were able to fund a liaison position through the SPNS initiative who is dedicated to this project and who is also bilingual in English and Spanish to best serve the clients who we knew we would be seeing through this initiative. One thing that particularly attracted us to partnering with Mass Hire downtown Boston is their really demonstrated experience in building programs through partnerships with external agencies. So they understand what the benefits are, what the limitations might be, what kind of flexibility and adaptability is needed, and they were really excited and ready to go to work with us on this. Okay, so next slide, please. So at a systems level, we did a couple of things to try to bring our organizations, Fenway and Mass Hire, together. We did a lot of cross training, and we did that on site at both locations. So we invited their staff to come to us, and we also sent our staff, including new staff on a rolling basis, over to them. We developed some introductory materials specifically for the clients in this program. And we also got really consistent with our practices around outreach attempts. So I think that we were not necessarily starting on the same page about how much outreach we would need to do to reach particular clients, and especially the population that we served through this initiative, but we were able to communicate and really define really well what the outreach practices would be. Next slide, please. Okay, and then a little bit more on the client level. So we saw after the first phase of the initiative that our clients were having a hard time making the transition from coming in to see us in our offices to making it to mass hire to access services on location there. So this was derailed by COVID, obviously, but prior to that, we had a really nice arrangement co-locating the mass hire services within AIDS Action. So folks would often come in and see their housing advocate and then also see the employment services navigator. So that was working really, really well until, everything changed. We also really established a strong communication and link between our liaison in the SPNS Initiative, who is our project coordinator, and then the employment services liaison there. Next slide, please. And then moving on to the second major goal in our initiative, which was internally. What are we doing to strengthen our systems internally? And so this initiative, coincidentally, coincided perfectly with the merger between Fenway Health and AIDS Action. And so pretty early on, a few barriers became apparent. One was our medical case management program and our housing program were pretty siloed, which is, I think, a pretty common experience. We are operating at multiple locations, and we were using 2 different data systems. So for all of those reasons, a lot of things weren't connecting, and we saw a lot of potential there to strengthen our internal systems. Next slide, please. So we employed a few key strategies to address those barriers. One, we developed a project coordinator position that was funded through the SPNS Initiative, and having that key person was really critical to communication and to keeping all of our efforts in this initiative organized. We started to have biweekly project meetings that included staff from the housing and the medical case management programs. We gave key staff access to both data systems, and that was really important to kind of break down the blind spots between what we were doing with clients and entering in multiple systems. And then we leveraged our quality improvement program within Fenway Health, and really had our QI program coordinator become a part of the SPNS Initiative team. And she was very present and able to facilitate a lot of really positive change through those projects. Next slide, please. So these next few slides just give a little bit more detail. I'm not going to talk through every bullet point here, but it was really, the project meetings were really about bringing programs, QI, and data and evaluation staff together on a regular basis, and planning around coordination and connection between our teams. Next slide, please. Our quality improvement projects, we used several QI techniques. We especially employed process mapping and identified barriers. We addressed our really long housing search wait list and found a way to communicate with each other in our data systems through a particular housing note in the electronic health record. And then we really leveraged our data and evaluation team as well to generate dashboards that help to keep us on track. Next slide, please. And then, as I said earlier, we gave some of our key staff access to our data systems. We talked internally to figure out the best ways to communicate within those systems. One example of that is using a flag in the EMR versus sending an email. And I think that it became apparent pretty quickly that our medical case managers really liked that communication within the EMR, and our housing staff was very used to sending emails. So understanding where each other was coming from and kind of coming together on those strategies was extremely helpful. Next slide, please. And then when we think about sustainability, so this project is over, what are we able to do and retain beyond the funding of the SPNS initiative? And so we were able to continue supporting our project coordinator for a period of time after the initiative ended. We were able to leverage HOPWA supportive services funds to do that. And we, in that period after the project ended, really built up our employment services knowledge and resources, and our staff continues to use all of that information to this day to better assess our clients' needs for employment support, and then also make appropriate and connected referrals. Our biweekly project meetings are going strong. We are still using data to inform that work, and we are still very much engaged in a lot of QI quality improvement projects that we work on as a team. So it has become much broader and very effective in bringing our different departments within Fenway Health together. So I've taken more than my allotted time, so I will stop there and turn it over to Tanya, and I'm happy to answer any questions later on.
Hi, good afternoon, good morning, depending on where you're at. My name is Tanya Colpan Mendez. I am the director for our Ending the HIV Epidemic program here locally. I work with University Health, and we are located in San Antonio, Texas. Next slide, please. And you can go to the next slide. So we are Bexar County Hospital District doing business as University Health. We have over 100 years of service in San Antonio, Texas, and we were founded in 1917. University Health is the only safety net health system in South Texas, and this means that we serve individuals who are low income, the vulnerable populations, individuals who are underinsured and uninsured. We are a level 1 trauma center, and we serve a 28 county region across South Texas. We have over 900 physicians and residents, and we have roughly 9,000 employees with the health system. Next slide, please. So San Antonio is the 7th largest city in the United States. Bexar County, which encompasses San Antonio and the surrounding areas, is the 4th most populous county in Texas. To provide some perspective, this is slightly larger than the state of Rhode Island. For the counties we serve, 94% of the region's people with HIV can be found in the San Antonio metropolitan region. We are a minority majority county, and so that means that the majority here within the region is the minority. So we have 60.7% of our population is Hispanic, and this is significantly larger than the Texas percentage of 39.7 and the nation's of 18.5. So next slide, please. So here are our mission, vision, and values, and I won't take time to read through all of them. Next slide, please. So I wanted to spend a little bit of time talking about how we are set up here locally. So the Ryan White Administrative Agency is housed at University Health. This was actually transitioned over in 2017, right around the time that the SPNS project started here. So we are the recipient of Part A. We're a subrecipient of Part B from the state. We have Part D funding, HOPWA, state services, state funds, and ending the HIV epidemic. Our Part F grant, the local SPNS project that we're here talking about today, actually ended in 2021. And so it's currently not operating. However, I'll talk more about that in a little bit. We serve the San Antonio Transitional Grant Area, which is made up of 4 counties, which include Bexar, Comal, Guadalupe, and Wilson counties, which are pictured on the bottom right of the screen. Together, those counties have approximately 2.4 million individuals. So some of the specialty partners we worked with are the Family-Focused AIDS Clinical Treatment Services, which is known as the FACS Clinic. The FACS Clinic is actually housed within University Health at our Robert B. Greene campus, located in downtown San Antonio. We also have subrecipients, including the Black Effort Against the Threat of AIDS, or Beat AIDS, San Antonio AIDS Foundation, or SAFE, Alamo Area Resource Center, ARC, or El Centro de Barrio, also known as Centro Med. Next slide, please. So our SPNS program began in September of 2017. And so pictured here is actually our Robert B. Greene campus. Again, it's located in downtown San Antonio. And this is in close proximity to where most of the clients served through this program actually resided. The building pictured here is actually our original building when University Health was first created. And this building here has been in existence since 1917. Our SPNS program actually operated out of this building, and our program staff included a project investigator, a program manager, an administrative manager, a program coordinator, 3 member advocates, a data manager, and a data coordinator. Next slide, please. So a little bit about our team here locally, and this is an actual picture of some of the staff involved in the SPNS program. And so our team was actually relatively new to HRSA grants. And so one of the approaches that we took to hiring individuals is looking for a diverse group of staff. So we hired individuals who had experience working at a law firm, and that law firm actually specialized in Social Security. And that individual had also previously worked at an insurance company who focused on verification and claims. Another one of our team members had a realtor license and assisted clients with numerous difficult housing situations. We also hired staff who had experience working with the state, experience with TANF. They also worked with CareLink, and CareLink is a financial assistance program that is offered through University Health. So the staff that we had hired had unique skill sets that helped us further the progress of the goals that we had. And so one of the key areas that the team looked at was focusing time to open lines of communication with partner organizations and additional agencies that could support program initiatives. So initially, we met with all 5 of the key subrecipients or key stakeholders. We also had reached out to other organizations such as the Food Bank, Goodwill, and other agencies that could assist with housing and employment needs. Dress for Success is another agency who helps provide clothing for interviews, etc. Next slide, please. So some of our program goals. So the goal was to enroll 100 clients into the program, and we enrolled 106 throughout the project period. Of individuals enrolled in the program, 83% identified as male, 13% identified as female, 1% identified as trans male, and 3% identified as trans female. Additionally, we enrolled 25 individuals who received services, however, were not formally enrolled into the program. So of those, we were able to complete 89 clients, and that meant for us, that meant that they had achieved both housing and employment. Next slide, please. So as we initiated the program, again, we first reached out to the 5 Ryan White service providers. And what we did in these first initial meetings were to inform them of the program and really ask for their support in referring clients who might be eligible for the program. And so what we did is we provided the eligibility document, and that was shared with their case managers, social workers, housing case managers, or other key staff at the agency. If a staff member found out or thought that a client might be eligible for the program, they would complete the eligibility form and send it to the program coordinator with the SPNS team. And this served as kind of a pre-screening for the clients. Additionally, we received referrals from other grant programs, both from within University Health as well as external programs that we had built relationships with. We received self-referrals from individuals who found out about the program either through a friend or through another source. And lastly, we reviewed data from the Ryan White data system. At the time, we were utilizing Aries. However, late last year, we just transitioned to a new data system. However, we did review this data to see if we could identify anyone who might be eligible through the data system. Next slide, please. So this is an overview of kind of the referral process into the program. But once the program coordinator received the referral, the program coordinator or the data coordinator reviewed the Ryan White data system and sought to complete an initial eligibility screen. They then updated local databases and the Ryan White data system, and we contacted the client up to 7 times to schedule an eligibility or enrollment appointment. This was actually feedback we received. One of the things we did was develop a advisory board, and through feedback we received with the advisory board, it was really encouraged for us to reach out to clients more than the traditional 3 times. However, so we increased it to 7 times. During the appointment eligibility, there was document signed, paperwork completed, and an initial intake was given. Once the documents were completed, the client was assigned to a member advocate to provide intervention services. The case manager was also informed if the client was enrolled into the program. The member advocate continued the work with the client to identify specific housing needs, barriers to achieving those needs, and work together to develop a plan of action when it came to their housing and employment needs. Next slide, please. And so in 2016, a housing study was conducted as a joint assessment by the Community Development Block Grant and the Planning Council. This study was part of a 5-year comprehensive needs assessment and served to better assess the housing situation in the transitional grant area. So let's take a look at some of the key points from this study. So respondents indicated that within the past 3 years, 90% of those surveyed had been homeless. Most reported they didn't have a support network to remain housed in the event an emergency came up. Roughly a third of individuals had difficulty paying rent in the previous 3 months. The top 3 barriers to obtaining housing included poor credit history, insufficient income, and lack of employment. The clients surveyed indicated that the location and condition of the housing they resided in were considered unsafe neighborhoods with substandard housing. When they were asked about reasons for which they might move, they reported drug activity, violence, street harassment, gangs, sex work, etc. Additional housing unit problems included bed bugs, mold and mildew. Some had incomplete kitchens or bathrooms. There were water leaks, broken windows, lack of running water, among other things. The timing of this study actually was key because this study this was actually going on at the time that the team was writing for the SPNS Initiative. So it was key to kind of include some of the elements into this as the SPNS program was being written. Next slide, please. So locally, I wanted to spend some time talking about some local housing support that we specifically worked with. There are housing options beyond the ones listed on the screen here. However, we specifically worked with a few agencies. Locally, 3 agencies received city HOPWA funds during the program, and 2 agencies received state HOPWA funds during the program implementation time period. I mentioned PHP here. It is currently funded. However, during the project period, it was not funded. Oftentimes agencies had wait lists that ranged anywhere from a few weeks to a few months. And the closer it got to the end of the HOPWA program year, the longer the wait times were to get on HOPWA programs. Carson House is a transitional housing space for up to 20 individuals. Clients, we often utilized Carson House because clients could be housed for up to 6 months at Carson House. And this really allowed us time to identify additional housing options once their time with Carson House ended. Another key partnership was developing or was working with the South Alamo Regional Alliance for the Homeless, also known as SARA. They do the coordinated entry here locally. They also hold monthly meetings to identify housing options and opportunities, and also work to place individuals who are experiencing homelessness, and had a really robust partnership with agencies who were able to house individuals. Haven for Hope is a low barrier emergency shelter where individuals experiencing homelessness can take refuge as needed. They have a courtyard, and clients who stay within their courtyard have access to meals, safe sleeping, shower facilities, medical care, mental health needs, etc. The San Antonio Housing Authority is the local housing assistance program, also known as Section 8 housing. When the program started, SAHA had roughly a 6-year wait time before a residence was able to be identified for that individual or family. And then throughout the program, we did see the wait list had reduced to roughly 3 years. And so we did encourage individuals to sign up for the SAHA program, and we really worked to identify additional housing options while they were waiting for that residence to open up. We did work with some smaller organizations such as St. Vincent de Paul. We were able to assist a few clients with one-time payments through St. Vincent de Paul in the event that they were short on their full rent needs, etc. And then identifying these resources and forging good working relationships, staying up to date with the resources available. We also really work to stay up to date with who the point of contact was at each of these agencies to help reduce barriers individuals faced when trying to work on their housing needs. Next slide, please. So I wanted to spend a few minutes, and I apologize, I know I'm over my time, but I did want to spend a few minutes going over a case study about an immigrant who faced multiple housing challenges and what steps we took to address those needs. Next slide, please. So this case is about a female named Louisa. I did remove personal identifiers. So in the second year of the program, a Honduran immigrant woman was enrolled into the program. She was assigned to our only fluent Spanish-speaking member advocates on the team. Louisa had recently widowed. She was undocumented, and therefore she was not on the mortgage note that they had. Additionally, Louisa's husband had not been able to work a few months before his passing, which resulted in the mortgage to fall behind by several months. The house was now in foreclosure, and after his passing, she found herself as the head of the household. She had no formal employment experience, and Louisa had 4 children to support, and 2 of her American-born children were also living with HIV. Next slide, please. So there's multiple challenges to address, and the member advocate really had to work with Louisa. We were really fortunate at this time to have a realtor who was also a member advocate on the team and really helped navigate Louisa through this difficult situation. Efforts to stop foreclosure were made. However, the member advocate reached out to one of the agencies who received HOPWA funding. However, unfortunately, since the mortgage was not in Louisa's name, they weren't able to provide support at the time. Efforts were made to sell the property. However, there were liens on the property and it made it difficult to sell. The buyers and investors didn't want to become responsible for the debt owed on the property. Louisa was mourning the loss of her husband, and she often expressed how much she had missed him. He had been the one who financially took care of the family, and again, she had no formal work experience. She now had to find a way to provide and support her 4 children. Their eldest child did work to help pay for necessities. However, they often found that their needs outweighed the monthly income earned. And then with no family support, Louisa really leaned on a friend she had made within the past year. And this friend is actually how she entered into the program. So next slide, please. So here's a few strategies on what we did in order to address these needs. So the member advocate took the approach of working to empower Louisa at every opportunity. Multiple strategies were necessary to meet all of Louisa's needs. The member advocate connected her to legal aid specializing in the immigration process and humanitarian visas. The member advocate stressed the importance of keeping up with her medical appointments and encouraged her to make follow-up appointments when necessary. The member advocate spoke frequently to Louisa's medical case manager to ensure that she had any supportive services available to her, such as bus passes, grocery store gift cards, etc. They also worked to apply for Medicaid, food stamps, and CareLink, again, that financial assistance program offered through University Health. And so those were a few of the programs that they worked to apply for. The member advocate also provided guidance on real estate, specifically the foreclosure process, and provided really worked with Louisa and walked her through the entire process. That house was foreclosed on. However, Louisa's friend that we just mentioned assisted her in finding an apartment that was very lenient with documents required to obtain a lease. However, the downside of this is that the lease did come with a higher price tag, which again put financial strain on Louisa. Despite the higher rent, with a lease in Louisa's name, there were additional programs that could be made available to her. And so the member advocate did work with the HOPWA case manager and trying to find housing options available to her. And so throughout all of this, Louisa did gain momentum. And so as the member advocate continued to work with Louisa, she really began to learn some of her strengths and skills. And the member advocate noticed that Louisa always had a hot meal prepared for her kids and that she cooked with great ease. Next slide, please. And so the client actually really enjoyed cooking, loved it. Louisa began to offer her tamales to neighborhoods and friends of friends. Through conversations, the member advocate was able to, they were able to talk and really magnify her entrepreneur spirit by helping her promote her food as a catering business. And so local businesses soon made Louisa's meal a staple at their establishment and requested lunch and dinner catering services. And this really allowed Louisa to earn approximately 3 times more than she would have made before. And this income really helped, her become more financially stable and better able to support her family. And so next slide, please. So I wanted to spend a few minutes talking about best practices and lessons learned. Next slide, please. So some of the best practices are really just to meet clients where they're at. Clients have ebbs and flows in their lives, and the team continued to work with the client to meet the needs that were presented at that time. Communication was really key. We learned that clients' housing needs changed frequently, and that we kind of needed to think ahead of what might come up. The team communicated with case managers to fully understand what those clients' needs were. Some of the biggest issues we needed to find were when it came to second chance housing. So the team worked diligently to identify private landlords who didn't have rigorous intake processes, or to find apartment locations that were more lenient and didn't require large deposits or strict background checks. The team participated in monthly housing task force meetings that were hosted by organizations Sarah and Haven for Hope. Private landlords and apartment complexes also participated in these meetings. And so it was a key opportunity for the team to learn about additional housing locations that they could refer clients to. There were also quarterly housing meetings with HOPWA recipients, which furthered the team's knowledge about local housing situations and the needs here. Some of the lessons learned were really that mental health is, a strong challenge. And there were often times where a client had to be referred back to the case manager to assist with this need before we could move forward with their housing needs. And then we also had gentrification of neighborhoods, which contributed to a lack of affordable housing options here. And so it was often difficult for a client to secure a rental property when the cost of living was beyond their means. And so the team often utilized the housing network to secure affordable housing for clients in these instances. And finding agencies that offered assistance with application fees was also vital. One of the unique things we also did was to team up with United Way. They have a subsidiary of Bare Necessities, and it really helped to assist with just startup needs once an individual was housed, such as furniture, food, clothing products, cleaning, kitchen utensils, bath items, etc. Next slide, please. And we can go to the next slide. Some of our sustainability efforts, as the CASE program closed, ending the HIV epidemic, ending the HIV epidemic, a Plan for America was announced. And so we actually received funding for EHE and really worked to integrate many elements of the SPNS program into this new opportunity. So we really took lesson learned and best practices and identified what additional opportunities the program wished we had. And so from there, we really focused on integrating those elements into the program. And then also expanding on that. So we did expand upon the SPNS program and actually are working to develop a housing program that provides financial assistance for clients. And so with this, we're working to leverage existing housing resources and housing programs here to create a more comprehensive support system for the clients. And with this housing program, we're looking to provide, up to 24 months in order to help stabilize an individual's housing situation. And so those are some of the sustainability efforts, and I'm going to turn it over to Jessica now. Thank you so much.
Thank you so much, Tanya, and thank you, Kristen. Watching you all present on your interventions is really a nice trip down memory lane, and we really enjoyed working with you both so much. and your wonderful program. So thank you so much for sharing all of that. As mentioned before, my name is Jessica Flaherty. I work at the BU School of Social Work. We were the evaluation and technical assistance provider for this particular SPNS initiative. And I'm going to give you a quick rundown on what our the results of our multi-site were. And I'm going to go through them quickly so that I can leave enough time for folks to ask questions at the end, which I'm sure you have quite a few. I see that the chat has been busy, so I'm going to go quickly. And I'm advancing my own slides. All right, so we had some study questions. They were, are there differences in health outcomes over time for people with HIV by housing and employment status? So this was kind of the main crux of what we were trying to find out through our project. We also wanted to know what the factors were that were associated with improvement in employment over time for people with HIV, and then what were the factors that were associated with improving housing over time for people with HIV. We used Mittler's consumer engagement in healthcare model as a framework for understanding how social determinants of health impact engagement in HIV care. So in other words, for our project, we were looking at how increases in housing and employment could potentially engage and retain people in healthcare and ultimately impact viral suppression. We collected data between May 2018 and August 2022. We were primarily looking at client outcomes and implementation activity and process outcomes. So we have an interview that was conducted at baseline, and then also post 6 and 12 months, so post enrollment in the intervention. Evaluation staff also collected medical chart information, and when we conducted the chart review, we did that at a couple of different points at baseline and 6 and 12 months post enrollment, but also we were able to conduct a subsample, or were able to collect information on a subsample of our overall sample for 18 to 24 months, which is really great as well. We also gathered information on the implementation activities through daily encounter forms. These were done, completed by the interventionists, so we could learn more about the work that they were conducting with their clients. And we also conducted a qualitative sub-study with a smaller portion of our participants. So here is, so we're going to go over our analysis a bit. And some of the limitations. Some of them will be very obvious, but so in terms of analysis, I will share with you a little bit of our descriptive data on clients that were served, and we used a bivariate and multivariate analysis to assess the factors that were associated with the health outcomes in the employment and housing statuses. There were 106 participants that we needed to exclude from our results because they never sought employment through the interventions. And then, of course, we had a little challenge around COVID, and so we have some missingness in our data where there were delays or there was an inability to conduct a medical chart review because of access to the medical chart data because of COVID, and or the client was lost to follow up because they had no phone or internet access or were otherwise unfindable during the first few months of the pandemic. Okay, so the interventions that were funded by the SPNS Initiative served 1,261 clients, and of those, 1,082 of them were actually enrolled in the multi-site evaluation, either because they chose to or they met the eligibility criteria. In terms of housing status, when they came into us at baseline, and if you remember before with our eligibility criteria, the majority of them were either literally homeless, unstably housed, or were at imminent risk for homelessness. Those who identified as male were obviously well represented in this study. In addition, we had a range of age 31 to 54 as the majority of the participants. Also, the majority of participants were born in the US and had completed high school and even some college or a bachelor's degree. So you see at the bottom there, we actually had quite a few people who for whom education was not necessarily the barrier. And then as far as race ethnicity, we had 43% that identified as African American, or 33% that that identified as Hispanic or Latinx. So we'll see some of the other characteristics that we found were that 67% of the individuals who were enrolled in the study were had prior incarceration history. Many of them were in their charts had diagnoses for depression or anxieties or other mental health diagnosis. 40% had trauma history, self-disclosed experiences with trauma and trauma history. In addition to there's a high sort of substance use risk, although as you can see, the highest was really tobacco and alcohol. And then we have cocaine and opioids at only 11% there. We did see very high food insecurity for the majority of the individuals that were enrolled in the interventions. And then in terms of viral suppression, we saw that 88% gained or maintained their virally suppressed status at the end of the study. So in terms of changes in housing status, for the most part, so we saw that 23.9% remained or became unstably housed, but far more exciting is the news that the interventions were able to keep folks in either temporary housing or permanent housing, and either obtained a new level of housing status or maintained, and that was exciting for us to see as well. Okay, so then our changes in employment status. For the most part, we're seeing here that half of the sample remained unemployed. That's not, that's not exactly what we wanted to see. We hoped that it would be higher than that, however, or sorry, lower than that, that would be unemployed. But we wanted to point out that the permanent and full-time employment actually went up 40%, which was really good news. So this is a busy slide, but I'm going to try to break it down to some pieces that are the most important. This is essentially showing us what were the employment barriers that that individuals endorsed in their survey. And we can see at baseline is red, and at 12 months is the blue. And so you can see a reduction over time that's pretty fairly dramatic around some of these barriers. So we can see that for those who participated in the interventions, they did see some reduction in barriers to obtaining employment, which is great. I'm going to point out at least two here where you'll see that there wasn't as much of a significant decrease over time. So things that are around fear, so fear of job skills being out of date, we didn't make a huge impact there. And then the fear of coworkers discovering my HIV status. And so those were two pieces that people came into the study with across the board where they experienced fear and stress that they wouldn't actually be up to snuff as far as returning to work or seeking a new job, or that they might be found out as somebody who is living with HIV. That is something where I think in the future we would love to see there be a little bit more of an impact on these barriers. So housing and then viral suppression. So you can see the red bar is virally suppressed and the blue bar is not virally suppressed. And you can see that a very significant change here where folks were permanently housed, where we saw that viral suppression really increased for those individuals who had someplace they knew that was their permanent housing. And then we've got employment status and viral suppression. So this, again, we're seeing some interesting, I think, information from this study. So we saw that where people were, again, virally suppressed is red, not virally suppressed is blue. Those who were not employed, their viral suppression was higher. And same with temporary, but when people moved into permanent employment, we see those numbers flip. So that was just kind of an important thing to know. Okay. So some of the factors that were associated with improved housing and employment status were that there was a high number of social support networks. And also if there was no recent history of incarceration, this is not a surprise to anyone, I'm sure, but if you did not have a history of incarceration, it was easier for you to get a job. Previous employment history and addressing needs for mental health treatment were significantly associated with improved employment. So when you can have an intervention that will address some of those needs, we'll see significant improvement in their in employment. So let's get through that animation. So this is just to give you a snapshot of the actual work that the interventionists did over the course of the study. So there were 11,570 encounter forms that were collected. Almost 9,500 of those were direct client contact. So that means actual either FaceTime or phone time or other time with the client themselves. And then 2,092 of those encounter forms were completed for work that was done on behalf of the clients. So it could have been outreaching to a program, a housing program, an employment program, something like that on behalf of the client. Of the direct client contact, 47% were around housing activities, 30% were employment activities, and 15% were medical care support. There was an average of about 9 encounters per participant, so 9 times that it took to work with the client in order to get them to achieve the next step in either housing or employment. By and large, it seems like it took mostly 5 encounters to get someone to the next step in terms of their housing, and 4 encounters for employment. And then the average duration per encounter with the client was 38 minutes. So less than an hour to work on housing and employment. And then the average caseload for an interventionist was about 32 clients. So as I mentioned before, we did a qualitative sub-study. So we got these really great quotes from many of our clients. And so one of these statements just included that this client felt that they became more confident with themselves and the stuff that they do, as far as when it comes to HIV, STIs, PrEP, resources, just me being more confident, more of a confident person. And then this one is about how they felt about their SPNS interventionist, the person who was working with them, and just talking about that their SPNS interventionist was really great about pointing out job fairs, because you go and you meet with different prospective employers. Always felt like I've been supported in finding environments like these. I am as an individual, or fit more of who I am as an individual. So I can't praise enough the SPNS interventionist for always reaching out to me and saying, here's the next opportunity. So a real connection to the client is what we saw made an enormous difference in terms of whether they were able to achieve viral suppression, if they were able to get a job or better their housing experience. So some more lessons learned from us. This is from the multi-site, which just kind of adds to all the really great lessons learned that we heard already from Kristen and Tanya. But housing and employment stability is not a linear process. That people make gains and then they experience setbacks, and a lot of these are related to all of the barriers that the individuals experienced around their HIV status, around mental health, around all of these other kinds of things that were getting in their way and creating barriers for them. We did note that the need for a champion was really important in terms of people achieving success in those areas. We know that social support and networks were crucial. If we didn't have, if individuals didn't have opportunities to connect with each other about what they were doing as far as getting a job or housing, that was one of the things that we noticed. Many programs provided that space for clients to talk to each other about their strategies, tips. Hey, there's this place over here that I know is hiring. All that kind of stuff was really important, and we found that many people reduced isolation that way, and were able to find jobs and housing that way as well. And then dedicated staff for, as we mentioned before, just spending that time with them, doing that coaching work, doing that empowerment work that Tanya spoke of. We also know that there is a role for emergency housing support, and we know that that a lot of programs who also worked either had a HOPWA program in their agency or worked in partnership with a HOPWA program. That was how we determined that this was an incredibly important piece. Also, private landlords and business owners were a really important piece as well. Getting private landlords to accept housing vouchers and all of that stuff is it's a lot of work. And a lot of the sites that we know spent a lot of time developing those relationships with private landlords, and the same thing with business owners in terms of getting people jobs. Have to develop that relationship in order to get employers to understand that the needs of people who are returning to work who are living with HIV are going to have different experiences, and how to make the programs, how to make the jobs more accessible. Department of Labor partnerships were challenging for some SPNS clients. One of the reasons is because a lot of the jobs, there were challenges if you had an incarceration history, if you were also managing mental health challenges or substance use issues. And so just wrapping up, we have a ton of materials that we've collected from all of the various sites, including manuals from each of the sites, and their intervention manuals are brilliant and beautiful and are available on our Target HIV site or page. It's under the HIV Housing and Employment Project. That's where you can see stuff from Fenway, stuff from the Bexar County Hospital System, and the other programs that were funded through this initiative. So we've got manuals, we've got spotlights, we've got issue briefs, and case studies. All of the webinars that we created for this initiative can be found there, so you can see more of Kristen and Tanya if you want. Also, we had some presentations and recorded materials from other conferences and those kinds of things. And then also journal articles published on our findings. We have one so far, and others that are on their way. And then also a project monograph, which will be completed soon. This also just a little taste of what these project spotlights look like. This actually is for Fenway Health, and this is the most recent addition to our Target HIV site page, and you can read all about the ways in which Kristen and the team over at Fenway integrated HIV care, housing, and employment into an FQHC. And now I am going to cede the floor so we can do some questions and answers. And I believe that Marina, who also worked on the project, is going to be sort of taking us through that.
Yes, thanks, Jessica. Hi, everyone. My name is Marina Sullivan. I'm a program manager at the Evaluation and Technical Assistance Provider at Boston University for this project. We have a lot of questions in the chat. We have 5 minutes, so I'm going to try to get us through those. So I'm going to unmute our presenters and ask them some questions. So at the beginning, there was a lot of conversation about HOPWA money for housing development. I'll read kind of two related questions. Someone said, we'd like to renovate a duplex or two in our area to permanently port HOPWA vouchers into. Is this a fairly straightforward process? Someone also said, I've been curious about the potential of establishing a HOPWA facility with common areas, private apartments, and potential other workshops and services developed based on identified community needs. Is there structure to explore that sort of possibility?
Sure, I can go, and just, obviously with the limited time remaining, I can't get into this too much, but as I mentioned, development costs are eligible under HOPWA. And I saw, folks are really talking about the fact that, only 1% of funds are used for development and sort of how shocking that is. And a lot of that just has to do with some of the limitations around development under the program. I think it also has to do with the fact that over half of HOPWA grantees are health departments and might not have as much experience developing housing as maybe a housing development agency that's a grantee, or a community development agency that's grantee. But again, as I said, it's eligible. And if you have more questions specifically around the requirements for developing housing under HOPWA, with limited time, I actually just suggest putting your questions or any HOPWA related questions we don't get to today into the HOPWA Ask a Question portal on the HUD Exchange, and I can provide a link to that. And so for any development related questions or any other questions, you can submit your questions there and get a response within a few days.
Thanks, Amy. Let's see, we had a question for Tanya related when you were talking about the referral process. Someone said 7 times sounds like a hard to reach client. How did you keep the client engaged after finally making contacts?
So we really use 7 times as kind of our point for everything. And where the 7 times really came into play was that initial contact from the patient. So as I mentioned, we received sort of a pre-screening from the case manager or another individual. And our team then worked to reach out to the client. And so it wasn't necessarily that it was a hard to reach client, but there's other barriers that are at play, such as a lack of communication. Not everybody, we have inconsistency with when phones are turned on, the amount of minutes individuals have on a monthly basis, whether they're connected to Wi-Fi or a hotspot at the time. And so all of those played a part in sometimes the difficulty in getting a hold of individuals. And so once we did get a hold of them, really the focus was just to talk to them about the program, scheduling a time to meet with them, to go over the survey, et cetera. We also utilized the case managers and reached out to them if we were getting close to the 7 times to just ask for their support in communicating with the client. I hope that helps.
Thanks, Tanya. And I will do one more question before we show contact information. Kristen, I saw that you were answering a bunch of questions in the chat. I'll just read one off if you want to answer it for everyone listening, the audio. Do you feel like some of the silos were broken down between Ryan White, HIV/AIDS program, and HOPWA case managers as a result of this project?
Yes, definitely. 100%. That has been probably one of the biggest lasting impacts. We are really coordinating and aligning between our housing programs and our medical case management program in such a different way than we did at the beginning of the SPNS Initiative. So we really got the support and boost that we needed through this initiative to achieve that.
Great, thank you, Kristen. And I see that we're at time. We have contact information for all of the presenters up on the screen right now. We'll leave it up for 30 seconds, but this concludes this webinar. And again, the recording for this webinar, as well as these slides, will be available on our Target HIV project page, which I'll post again in the chat, and they should be available probably by the end of next week. Thank you, everyone.
Thank you.